Hello, everyone. We're ready for a CCO student webinar. We're on number 97. And like I always say, I know you get tired of me saying it, but great topic tonight. There's always a lot of confusion, especially for, our students, that when we get to working with E&M, what is the proper way to distinguish 99213 from 99214? Now, these are E&M codes. The way you can tell they're E&M codes is they're 99 codes. Now, if this is for established patients, we could do the same thing for new patients, but and the rules are slightly different for new patients versus established patient. But for the most part, they are so similar that if you can understand how it works with the established patient, and leveling those, it's going to work for the new patients as well because it's the concept that you're trying to get under your belt. But it's pretty obvious what is a 99215. That's the highest level that you can get in the outpatient doctor's office. And, the person has to have multiple diagnoses, complications, lots of tests being done, and the person's not going to get better on their own. And they're really, really a complex and ill patient. Whereas the extreme opposite of that, when you're dealing with, say, a 99212, the patient, pretty straightforward, not much going on, simple medical decision making, ultimately. And so those two extremes are kind of, no brainers. They're even a person that's relatively new and a novice at coding can figure those two out. However, where we get into a little bit of uh, heavier thinking, gets a little more complex, is when you start looking at that middle ground. What's the difference between that level 3 and the level 4? They're so similar sometimes. And unless you understand the disease process, what's a more complex diagnosis, what are the procedures and everything that go along with treating these diagnoses, whether it be screening or diagnostic tests that are being ordered, medications involved, then it it feels a little ambiguous. Like, well, what's the difference between them doing this versus that? Again, it's like I don't quite understand. Now, if you have more experience in the medical field, then some of this seems pretty basic. Now, I can tell you, and I'm not bragging, but for me, understanding the difference between a level 3 and a level 4, now that we are based on medical decision making, again, it just makes sense to me. It's very, very easy. But that's because I've been doing it for a long time, and medical decision making is my world. That's my arena. I work in predominantly the ICD-10 code set and in risk adjustment, and so this it just makes sense to me. In fact, I was so glad when we switched to medical decision making versus the way it was before, because we were always clicking off bullets, and I just wanted to say, well, of course it's a 99214 versus a 99213 because of the disease process or what's being done to the patient. And you couldn't do that. You had to click off all these bullets. You had to validate it in that way. Whereas now the medical decision making is what validates the difference between 3 and 4. So we're going to talk about that, kind of unpack it, and both hopefully from a standpoint as a student, if this is new to you, or if you've been, involved in your credential for a while, but you're still struggling with the nuances, especially since we have that change recently with medical decision making, then this hopefully will be enlightening to you. And maybe if you are in a position where you need to assist with your peers that are struggling, then you can use this information again to help you along the way. So we're going to compare 99213 and 99214. The way we're going to do that is we're going to look at the two as they're described in in their descriptions in the manual, and then we're going to look at the coding clinics that are out there for both 99213 and 99214. And after that, we're going to look at the coding clinic examples that are given, and I'm going to unpack those why they are answered the way they are. And last, we're going to wrap it and put it all together with some scenarios that I came up with that I'm going to allow you to practice with and say whether you think it's a 99213, 99214, and then I'm going to tell you if you're correct or wrong. And then we're going to follow that up with the answers. All right. And so hopefully those scenarios that I came up with are closer to reality, what you'd be dealing with. Okay. Let's get started. The first thing we have to look at is really what is a 99213. All of the descriptions for the E&M, when you're looking at the established patient and versus the new patient, the descriptions are all the same. There's just a few things that differentiate one from the other. So these look like really, they look kind of long descriptions, but there's just a few things that you have to abstract from that. So let's talk about what that is. What you have to be able to tell is the difference between a new patient and an established patient. So if it's a 992-0, that indicates that it's a new patient. The rules are a little bit different for leveling for a new patient versus an established patient. And that's because the medical decision making is going to be a little higher anytime you're dealing with a new patient because it's new to the provider. It's going to take them longer to get the information, the PHI, and you're looking at any medications that they are on, getting their social histories and such. It just takes longer. So that medical decision making is kind of bumped up, right? It's a little more forgiving, I guess you could say. Uh, Less work involved to get to a higher level because it's a new patient. We know the medical decision making is automatically going to be a little higher for a new patient. However, for an established patient, that means that this patient is the provider is familiar with the patient, and all of that basic record keeping has been done already. So, we're not starting from scratch. So that lowers the bar for the medical decision making automatically. That being said, if it's a 9921, that gives you automatically tells you that it's an established patient. So if you're testing or looking at test questions, always remember that 9920 will be a new patient, 9921 will be an established patient, and that's the first thing you need to abstract when dealing with E&M. And so this is an established patient. So I went ahead and underlined that. And I encourage you, that's part of the process we do with the BAT technique that Laureen came up with back in 1999, is that we, bubble, highlight, and annotate the information. And so established patient, just go ahead and underline that it's an established patient. Now, the next step that you need to be able to understand about 99213 is what's the level of medical decision making. Everything else in that description is fodder. We don't care, right? So the key is low level. That's what you have to understand. So a 99213 or level 3 is low level of MDM. And I will probably refer to medical decision making going forward as MDM. It's just easier to say it that way. Now, throwing out the leveling, if the provider, it's more beneficial for the provider to go by time, that's there. And we know it's 20 to 29 minutes. Okay. But that's so simple. We're not going to talk about that. If the provider chooses to do that, or that's the way it's going to be beneficial to the provider, then just go by time. But not always is that the case. So don't think that that's a crutch and we're like, oh, we'll just use time and then I'll have to think about what's low and so on. Can't do that. That's different. So again, low medical decision making. Now that is not the lowest because straightforward is lower. 99212 is straightforward. So low is the next step up, right? And let's talk about then what's a 99214. Notice the description is exactly the same, verbatim, except for one component, moderate level of medical decision making. Still established patient. I go ahead and underline that established till you get used to, till you memorize that 9921 is established, 9920 is a new patient, especially if the ENM code set is new to you. So we've got low medical decision making and moderate medical decision making. The time 30 to 39 minutes. Okay. We're not going to talk about that again because that's extremely simple to use, but not always the most beneficial to the provider. And the guidelines are very plain to say that you can use either one, whichever is more beneficial to the provider. And often it is based on medical decision making, not time. So the difference between 99214 and 99213 is low and moderate. Now we have to understand what is the difference between low and moderate. And they're so similar that that's why it gets confusing. Not just for new students and people new to the E&M code set, also for us that are out there doing this every day, sometimes we'll sit there and think and debate. You'll hear the chatter and you'll see in the forums and stuff, hey, this scenario came up, but is it a 3 or 4, or can I get a 5 out of that? And it's not like we're trying to game the system. It is true, we want to give our providers uh, the the leveling that they deserve for the work that they're doing. However, we do have guidelines that we have to follow, and we can't be padding or adding. You'll find some providers out there, not as much, I think, anymore as we used to see in the past, because it's difficult when you had to click off all these boxes and make sure you met all the criteria. Medical decision making makes more sense to them also. But they would say, just make everything a 4 or just make everything a 3. I don't care if I lose money because I don't want to get audited. And that is wrong. Remember the motto that I keep telling us over and over again. We code for statistical purposes. It happens to be a convenient way to get paid. So not only is this a disservice to the provider, but it's a disservice to the patient. The medical decision making and the E&M is a statistic that has to be tracked. And so we want to make sure that if a patient is complex and they're being coded out as a level 3 when they should be a 4 or even a 5, then that's not going to track statistically. That's going to show that these diagnoses that are complex with lots of changes in the tests and stuff that are being done are the bar is being lowered for them, and that's not good. So we want to be as accurate as possible. We want to be truthful, and we want to both provide an accurate leveling for the work that the provider is doing based on the diagnoses and the disease process for the patient. Okay, that all being said, now that we know the description of a level 3 and a level 4, let's see what that entails. Okay, if we have a low versus moderate MDM, the complexity of the problem is key. Is this going to be the number of diagnoses and the management options that are considered during the encounter? Let's talk about what that means. If the provider gets a patient that has a new diagnosis, okay, that bumps the complexity up. All right. new diagnosis. If the diagnosis is complicating other diagnoses, bumps up. Okay. If it's an acute diagnosis versus a chronic, bump. Okay. See how, because those all uh, lead to complexity. The provider has to think more about what the is best suited for the needs of that patient based on those things. Now, low medical decision making would be minimal complexity. Okay. Usually they say straightforward problem and it's minor to a self limiting nature. Now, if you're new to the code set, you're saying, well, what's straightforward mean? What is minor or what's limiting even mean? So let's unpack that. Let's talk about what that is. Straightforward signifies that it's simple. It- there's no other way to say it. If a patient comes in with a headache and the provider states that this is due, they after they take all the information that they need, and their diagnosis is that this is a seasonal allergy headache, that's pretty straightforward. Nothing else going on, overall healthy patient. That's pretty minor. All right. It's going to eventually correct itself because once they're not in contact with the allergen any longer, the change of the season and the pollen and everything, it's going to take care of itself. So it's self-limited. It is not, it's not life threatening. It's not going to get worse. Whether and most likely the provider is just going to treat the symptoms and say, continue with Tylenol, and there's over the counter allergy medication, and give a suggestion as to which one's more appropriate for seasonal pollen allergies that give you headaches. Okay, so that would be low decision making. Even though it's a new diagnosis, that's all straightforward and low versus moderate decision making. What would that be? So, more complex, multiple diagnoses that the provider has to think through and manage, and having new or worsening problems. That's key. So, if they have a multiple diagnoses and the provider addresses all of those diagnoses. So if a patient has hypertension, hyperlipidemia, COPD, diabetes, and psoriasis, that is a huge number of diagnoses that the provider states that the patient has. But that day, they're only being seen for their psoriasis, and they need new refills because the cream that they gave them last time really worked, and they want to continue using it. What's the medical decision making there? First of all, it's a problem that the patient already had diagnosed. Yes, the patient has multiple diagnoses, but the provider states that they have them, but they're not addressing any of those. They're addressing an existing diagnosis that already has an action plan in place that's working, and the patient needs a refill to continue on with that. That's low medical decision making. However, if the provider states that that same patient with all of those diagnoses comes in and they said, I'm here for my psoriasis. That cream that you gave me is working. I'd like to refill that. But then the provider looks at the patient's arm and says, you know what? The skin is not, it looks better as far as the psoriasis is concerned, but your skin is really cracked right there and it's bleeding and it looks red and inflamed. I think you've got an infection going on here, and you're diabetic. So that's problematic. So the medical decision making now involves two diagnoses: the psoriasis that has an established plan of care, you're going to refill that. But he noticed, we've got a second diagnosis going on. That's a problem. because it is complicated by the fact that diabetics don't heal as well. And what happens to a diabetic when they get a wound? Not only they do not heal it as well, but they have complications of infection is higher, and the thought of the complications that they have to consider would be higher. What if the patient is not able to take a multitude of antibiotics? And so there's only a few antibiotics that the patient's not allergic to, and not all of and the ones that they're allergic to are the best antibiotic to treat a skin infection. So then the medical decision making just got bumped up even more. Now, this is not life threatening, but you see how the provider has to start thinking. It's like, okay, I got to think outside the box. The medical decision making just got bumped up to moderate because we have two diagnoses, and one is okay. We're working with that. But this new one is an acute new diagnosis that could be a major problem if we don't get it controlled. That becomes a four. Okay. Good. I'm glad this is helping you, this breakdown. This is the way my brain thinks. And I like to be able to give these examples like that because I think it kind of brings home, now I understand. Low, everything's going fine. Even if it's a new diagnosis, it's easily taken care of. The provider doesn't have to do much regarding that. But if we have multiple diagnoses, whether they interact with each other or not, the complexity of that medical decision making is goes up for the provider. Now, there's still rules that surround what entails elevated medical decision making within there, but the basic framework is in place now. All right. Uh, Next, for low versus moderate, we have to look at the amount and or complexity of the data that's reviewed. This is again where people that are in the medical field or have a little bit of understanding of the medical field under their belt, they excel at this because they recognize all of the data that's reviewed: lab tests, imaging, pathology reports, consultations, past medical record, so on. These are the things that they understand. And so if it is something simple, like just reading a lab test, and it's a common lab test that's done all the time, and you're just monitoring the patient's levels, that's really not high complexity, especially if it's something that's established. And if a patient has hyperlipidemia and they're getting their cholesterol checked on a routine basis and everything's fine, is that really does that really constitute a higher level of medical decision making? It does not. So just the fact that the provider looked at the labs and documented the lab results and that they verified the lab results, that's not increased medical decision making. It bumps it up a little bit because they did. They took the time to review. They do have to monitor it. They do have to stay on top of it. But if everything's routine and going along as planned, that's not complex. And so that's going to be a 3, not a 4. However, and so that would be minimal. They do have data that they're reviewing, but again, it's not that complex. Whereas with moderate, that's more extensive data. So let's say let's say our patient that had the hypertension, the hyperlipidemia, the diabetes, the COPD, and the eczema. Okay. What type of common labs and or data would the provider look at? Well, again, if it's just the um, eczema that the patient is being seen for, and everything's going fine, there really is any even if he says, yeah, the last labs everything looked good. That's still low. even if they did the labs and he said, "Oh, by the way, your labs last time were low." Yeah, he gets credit for looking at those and explaining those to the patient, but everything's fine. Versus the patient comes in and he says, "Hey, I've got this eczema and the medicine's working great. I want to get a refill for that. But overall, I feel pretty good." And the provider looks and he says, "Oh, by the way, that doesn't look good, actually." And in fact, he may say, "You know what? Let's do a culture of that. I suspect that there could be something in there that might be growing, even though you're saying that the medicine is working and that you're not getting the itching and everything." Um, Plus, the antibiotics that I would put you on for that, I'm reviewing the data, and it looks like you are allergic to a lot of antibiotics. And so I'm going to have to go back and reference which antibiotic is going to work well for you. In fact, I think I'll just call the pharmacist and let them advise me on what we should do, whether we should try a topical antibiotic versus some of these oral that you are allergic to. Let me get their opinion. Bump up, because he had to reference somebody else and look into that data. Then he says, "And by the way, when you came in today, your your blood pressure was abnormally high. Now, every time you've come in before, it's been real steady, and it looks like the medication is working, but today it's not. So I am not sure if that's a new diagnosis, something going on, or is it related to the fact that you may have an infection in your body that could raise your blood pressure? Because if it was just the white coat, your blood pressure goes up all the time because you come in and see me, we would have seen that reflected in all of the other blood pressures that I reviewed from the last, 6 visits that you had. So this is something new. We need to check that." And then they do more investigating and say, is it the fact that maybe you have an infection that raised it, or is it some other disease process that has started to happen? And is it because your kidneys are giving you trouble and you weren't aware of it, and it's raised your blood pressure because you are diabetic? So again, the thought process is in there. That just bumped it up. So now we're a 4. Okay, good. I think you got an understanding of that. The last thing that involves the difference between low and moderate MDM is the risk to the patient. If we understand risk, that is complications of morbidity and mortality. Now, the difference between morbidity and mortality is the fact that morbidity is what's going on with the disease process, whereas mortality means you're going to die. You're mortal. You're going to die. So understand the difference in those two. If you don't, write that down, do a little research. Now, for potential risk, we need to look at the management of the options. For low, it's usually minimal, low risk situations. Hey, that medication is working great for your eczema, and we're going to continue as planned. I'm going to give you a refill on that. Everything looks good. That's low, minimal. Okay, so he is saying, yeah, I've reviewed your records, and it looks like that is working great. Let's continue that, but let's continue to monitor it, because the fact that you're a diabetic, I I want you to come in and check in with me again to see that that does continue to work. And sometimes the medications that you give for those type of skin conditions can affect your diabetes and so on and so forth. Now, for moderate decision making, again, moderate risk, go back to, hey, you've got this infection. It looks like, in where that scaly skin has happened, whether you've just bumped it because, again, the skin is irritated and the scales gets can slough off. And if you weren't diabetic, it probably would be fine, but because you are, you've got an open skin area, open wound there, and obviously it looks like something is happening. We've got an infection. The risk, if we don't do anything, is higher. It's moderate. Now, are you going to drop dead from this? No. Is the morbidity and mortality really high? No, you're not going to be a 5, but it's absolutely a level 4, because if we don't do anything, because of the morbidity, the whole fact that you're a diabetic with an open skin wound, even though it looks minor to you, is much more complex to a diabetic than if you weren't a diabetic. Okay. He would just say, hey, let's let that go and let's monitor it. But as a diabetic, no, we're going to do more than monitor it. We need to be proactive, make sure this doesn't get worse. Or your likelihood of getting an infection, going septic, and dying is higher. Again, moderate. So you see where we're at and those areas that make you change. Now, the key here is that you have to have two of those three things to be able to go to that next level whenever we look at those. So now that we understand the difference in what it takes to go from a level 3 to a level 4, the 99213 to the 99214, we have a better understanding of that. Let's look at what Coding Clinic has given as an example to help us educate us in some other nuances that could make the decision for you in going from a level 3 to a level 4. We're going to look at the questions that have been proposed, and then we're going to look at Coding Clinic's answers. If you're not familiar with the way Coding Clinic works, it is the panel of experts that everybody relies on to make final decisions. Whenever something is not black and white, there's a gray area, and they need an explanation as to what are we going to use as a guideline or a rule in this gray area. You go to Coding Clinic, and Coding Clinic is the reputable advisors that everybody understands. They are the expert, so whatever they say goes, more or less. That's the easiest way to tell you how it works. That being said, Coding Clinic is out there, but you have to pay to access it. Now, your employer usually gives you access to Coding Clinic, or they have access to Coding Clinic. It is not cheap. It is an investment. I don't remember what it runs every year, but it's significant. And again, do not quote me on this. Go look it up. But I'm sure it's well over $400. And so you, this would be an investment if you choose to get Coding Clinic. Now, information in the archives and the backlog of information is absolutely brilliant and worthwhile. But if you're new and you're a student, you really don't need Coding Clinic yet. Rely on being able to go in and your instructors to be able to look that information for you. Also, you have resources in that you can go research a scenario, and somebody probably has already referenced Coding Clinic for you. And whenever you see something that is a Coding Clinic answer or referenced, you know that's reliable. So you can trust the information that you're given from Coding Clinic. So if an article's done on, say, how to code out psoriasis, you know, that particular code, you can trust that the Coding Clinic that was referenced was accurate, and you can move forward. So we're going to look at a couple of these that are applicable to these specific E&Ms, and you can go back and reference them as you need to in the CCO student area and the club. The first one, the question that was proposed to Coding Clinic is: a patient presents with calf pain, and the physician orders a stat ultrasound to rule out a DVT. Now, following the review of the test results, the physician later documents that the patient is stable enough, then there's no concern of a pulmonary embolism. Does this scenario meet the MDM for moderate, a 99214 or 99204? Notice that's established or Newton, based on the number and or complexity of problems addressed and the risk of complications and or morbidity of mortality of patient management due to the need to initiate or forego further testing, treatment, and or hospitalization. So what they're actually asking is, the patient, the provider thought they had a DVT, some type of an embolism, and that it could become a pulmonary embolism, and could go to the lung. So that's an acute critical problem. that's life-threatening, and they order a stat test, an urgent test, and it comes back negative. So, does that mean it's a moderate? I mean, it looks like it meets the criteria, but the person is really asking, saying, "Yeah, but everything turned out fine. So is it still moderate?" I don't know what you're thinking. Just in the chat, go ahead and put whether you think that it would be a level 4 or it would be a level 3. And you can just put a 3 or a 4 in the chat. Feel free to do so. And we'll get to the answer real quick here. I'll just give you a moment to do that. Very good. All right. So again, we're thinking about whether you think this constitutes a 3 or a 4. Okay. Let's look at the answer. This is the key. This is the learning point the coding clinic tells you. And you have to understand this with medical decision making. That's why I picked this one to put in. The risk and complexity does not change with the outcome of the diagnostic test. So the medical decision making, it doesn't matter that the patient did not have a pulmonary embolism or a thrombus that was going to go, a DVT. That didn't matter. What mattered was the fact that they had all the signs and symptoms. And so therefore, these tests were done. The medical decision making is based on what the provider thought that the patient had and the level of risk, the level of data that was reviewed, and the number of diagnoses, and if it's a critical or acute. Uh, just because the patient didn't have it doesn't change the medical decision making. The outcome doesn't change the work that was involved to determine whether the patient had a DVT and was going to get a pulmonary embolism. So the answer is it's a level 4. It's not a level 3. Do you understand why? Okay. So based on the assessment and the risk of mortality and morbidity, they did a stat ultrasound because guess what? A DVT is life threatening. What does a DVT turn into? It turns into a pulmonary embolism and you die quickly when you have one of those. He has all the signs and symptoms of this. Now, did he end up having one? No. But if he had, that's life threatening. Okay. So again, the amount of work that went in to taking care of this patient is not based on the outcome. It's based on the work that was done. Thank the good Lord the patient didn't have this. But if they had, then we could have even probably gotten into a level 5. Okay. So, again, this would be a 4. Critical to think about. So we're going to say it again. The risk and complexity does not change the outcome of the diagnostic test. All right. That is something you need to write down. So we've got our second coding clinic question. In a practice with practitioners who see a lot of patients with Alzheimer's disease and dementia who live in an assisted living facility, all of the patient's medications must be prescribed, including the over the counter medications, so that the facility may administer them. Would prescribed management of over the counter medications be considered prescription management in the MDM element of risk for the appropriate E&M code? So, what are they really asking here? They're saying that uh, whenever a patient is in a facility like this, assisted living, at home health, their medication is taken away from them and it has to be documented and tracked by the entity that is in charge of their care. It's this is it's always done. So whether the person wants an aspirin, a Tylenol, it doesn't matter. Now they can request it, and an order would be written by the provider that says PRN. Whenever the person wants a Tylenol, they can have it, but it has to be given by the nurse. The patient cannot have a bottle of Tylenol in their room and just take it whenever they want. Okay, so therefore the management of the medication, even though it's over the counter, has to be done by the provider, and those orders have to be written. Now, there was kind of a saying back in the day that if a provider writes a prescription for the patient, it's automatically a level 4 because the medical decision making that's involved for a level 4, right, is part of its getting a prescription. And so that is kind of where this is stemming from is, you know, does this patient constitute a level 4 even though they've got a handful of over the counter medications that out in the world would not constitute higher medical decision making, but for us it does. How's that going to work? So the answer is next. And go ahead, put in there, you guys, whether you think this is going to be a 4 or a 3 for them to be able to do that. I see you're already starting to put that in. But taking a break, wanting you guys to know while you put those answers in that this is a student webinar. And our student webinars are exclusive to our students. Now, you may be getting a little sneak peek of how we do our student webinars. We wanted to be able to offer you that if you are not one of our students or in our CCO club. But if you are, then the rest of the story is going to be next. And you get not only the answers in the rest of the slide deck, and in replays, you can go back and reference this as many times as you want, but we also transcribe all of our webinars. So you get a transcript. Some of you may not be visual learners. You may need to be able to read what you're looking at. And so to be able to read that resonates with you and you can go back and reference it. So as a club member or as our students, you get to go back and watch the videos as many times as you want. You get to have access to the slide deck. You get the transcript of what we talked about. And on top of that, it's use. So this will probably be turned into a CEU because it is a high demand topic that a lot of people get confused in. If you want that, then go out to cco.us/club. And if you want to know the rest of the story, because you guys that are not members of the club or are not our students, guess what? The video ends here. And so you're not going to get to see the rest of the coding clinics or the examples that I created to flesh out the understanding of the two difference 99213 and 99214. Okay.